Welcome to the second section of joints. First thing we're going to take a look at is the shoulder joint. They're quite easy to remember, the ligaments of the shoulder joint, because all you do is take the lower bone marking and then add the higher bone marking. So for example, when we're looking at the acromion is right here, and the clavicle is right here. So the ligament between, you take the lower bone, acromion, and add it to the clavicle. So acromioclavicular is the ligament that's in between there. Then if we were to take a look at the coracoid process here, and we go to the acromion, then the ligament between that is coraco, because it's going from the lower bone to the acromion, so coracoacromial. Next, we're going to take a look at the coracoclavicular, because it goes from the coracoid process to the clavicle. The last major one of the shoulder is the glenohumeral ligaments, so going from the glenoid fossa, which is here on the scapula, to the humerus. And don't forget, you've got your bicep tendon right here going right down the front of your bicep. There's a few shoulder joint injuries you can get. Tendinitis, meaning inflammation of the tendon. So your bicep tendon, you could get that from overuse for things like throwing. A shoulder separation is the tearing of the acromioclavicular. So where the acromion here meets the clavicle, those ligaments there separate. Very common in hockey for people going into the boards, things like that. A shoulder dislocation is when the head of the humerus pops out of that glenoid fossa. And the glenoid fossa is that hole that was in our scapula. A rotator cuff tear is very common, usually for a fall with your arms out, or for an overuse injury playing throwing. Here's a look at the knee joint. In the middle you've got your patella, and then below that was the ligament, because remember there was bone to bone. We had our patella here, and then we have our tibial tuberosity here, and in between you've got that ligament. On the outside you've got your lateral collateral, which you can't see here, and on the inside you've got your medial collateral ligament. So it's on the tibia, so media, tibial, collateral ligament, and then we'll take a look at the side here. You can kind of see here where the lateral fibular collateral would be, because it's on the fibula. Here you've got your lateral condyle, so remember condyles are like peaches, it's like on the side of your knee there, and then you've got your medial condyle here. Underneath the condyles you've got a meniscus, and meniscus, if it tears, it can be quite painful. And then you've got your medial meniscus here. Something we all know more commonly as an ACL is your anterior cruciate ligament. So if you were to stop really quickly in a sport or get injured, you might hear a popping noise, and that would be your ACL, or anterior cruciate ligament. Behind the ACL is what's called the PCL, or the posterior cruciate ligament, and I'm going to put it in black right behind that there. So there's your PCL. As we look at the posterior view of the knee joint, you can see once again medial collateral, lateral collateral. The only thing that's a little bit different here is the oblique popliteal. So that's just going across the back of the knee there. And other than that, I don't see anything else really here that we need to move to the next. Once again, you can see your posterior cruciate ligament really well, and then your ACL here. There you've got your lateral meniscus and your medial meniscus and your lateral collateral and medial collateral. And then don't forget these things here are your condyles. So there's a few joint injuries that happen in the knee. Most knee ligament tears happen because of the Q angle. So the Q angle goes from your ASIS all the way down to the tibial tuberosity and then back up to the patella. So if this angle here is greater than 20 degrees, then you're at an increased risk for more knee injuries. So typically this happens to a lot of females because our pelvis tends to be a little bit wider. Osgood-Schlatter syndrome is where it affects the epiphyseal plate of the tibial tuberosity. So here your tibial tuberosity is going to increase in size, often happening more so in males, typically during the puberty time. And a lot of people who like run and jumping activities like volleyball and basketball, putting a lot of stress. And lastly, PFS or patellofemoral syndrome is where you get gradual onset of knee pain on and around the patella there. So with that one, that's more common in females. Now we're going to take a look at the ankle joint. Remember I told you earlier about this deltoid ligament. This deltoid ligament is so strong, and that's the main reason why we don't have inversion sprain or eversion sprains. So not a lot of eversion. So you don't too often go over on this side of your ankle because that deltoid ligament is so strong. And then underneath, you've got something called the long plantar ligament. And often in the summer, when you wear flip-flops and you don't have a whole lot of support, you might get what's called plantar fasciitis. Once again, inflammation of the plantar fascia gets super tight and it's very painful. So what you want to do is roll your foot on an ice cold water bottle or on a tennis ball. Here you can see all of the ligaments get their name from the bones again. So anterior talofibular, going from the talus bone to the fibula, posterior talofib, anterior tib fib, so going from the tibia to the fibula, and anterior talofib, and then you've got your calcaneal bone or your heel. Inversion sprains are where the medial side is up, so the medial side comes up on the ankle. Eversion, it's very uncommon. Only like 20% of sprains are eversions because of that strong deltoid ligament. If you do have an eversion sprain, a lot of the times you'll get what's called a Pott's fracture. And a Pott's fracture is when you go over, and often it rips off the tip of the medial malleolus and therefore breaks off a part of the fibula. So pretty scary when you do that. Now you're going to get a chance to create your own joint models. So start thinking about how you want to do that. Do you want to use clay? Do you want to use an old hockey stick that you found in the garage? Do you want to use styrofoam? What do you want to do to create it? And start thinking about whether you want to do the ankle, the shoulder, the hip, the knee, the elbow, because you can do whichever one you want. Look for the videos of my classroom where they've created their own. You're going to create a video of your step-by-step, day-to-day process showing me how you created it. Don't worry if it breaks. Just, get back on track because I'll see all of it on video. My students last semester, they got so upset because their finished product, some of it broke. But all I say is, hey, you've got a fracture in your bone. It's all right. So don't worry about things because you'll have it all done on video. Good luck with it all, and if you have any questions, let me know, but look for further postings of those videos from my classroom and on the joint models. Have a great day.